George asked you about how many of you were psychologists and doctors and so on. I'd like to just find out how many are working with children here? Okay, and how many working with adults with brain injury? Okay, so that's the biggest group. And that's certainly the group I work with. What about elderly people? Okay, and I know some of you are going to put your hands up for everyone. That's true. But so the examples I'm going to give are by and large from adults with non-progressive brain injury. But the principles, of course, should apply across the board. Now, we already know from various studies that cognitive rehabilitation can benefit people. And this is a quote from Cicerone et al. And the studies they did looking at the effectiveness of rehabilitation. And in the 2005 paper, it says, there's now a substantial body of evidence demonstrating that patients with TBI or stroke benefit from cognitive rehabilitation. So we shouldn't have to keep convincing the purchasers that it's worthwhile. And the kinds of problems that people, survivors of brain injury face were the motor problems, which are often the most likely to get treated, certainly in the UK. The cognitive problems, probably less likely to get treated. Behavioural problems, sensory problems with vision or hearing or touch. Social and emotional problems, problems with pain. Fatigue, a real big interest now in fatigue after brain injury. Two of our occupational therapists have written a booklet on fatigue, management of fatigue, which has just won a prize in Britain. So if anybody's interested in tracking that down, email me and I can tell you about it. But the cognitive problems that many of us will be dealing with, memory, attention, communication, planning, organisation, reasoning, perception, spatial awareness, and so on. The emotional and psychosocial problems, I think, that come up frequently, anxiety, depression, anger, fear, distress, grief, poor self-esteem, lack of confidence, etc. And the behaviour problems, I think the ones we're most likely to see in rehab, temper outbursts, shouting, swearing, physical aggression maybe, disinhibition, poor self-control, refusal to cooperate, etc. And of course, in everyday life, it's not the physical problems that cause the most handicapping. It's the cognitive, emotional, and behavioural problems. And these are more handicapping than the physical, that's the motor and sensory problems. And one quote by Can et al., 2003, cognitive and behaviour changes, difficulties maintaining personal relationships and coping with school and work are reported by survivors as more disabling than any residual physical deficits. But sometimes you try to get purchasers of healthcare services to recognise this. They'll pay for physical therapy and they won't pay for the cognitive, emotional, behavioural therapy. Oh, and this is that quote I mentioned, George. This is one of our patients. I live in the ruins of my old self. And as I said earlier, in rehab we need to draw on a number of models and theories or we risk bad clinical practice. And the particular models I think have been useful, models of cognitive functioning, models of learning, models of emotion, models of assessment, models of recovery. Some of these I've covered this morning, but not all. Plasticity, the holistic models, etc. Now I'm going to, if I can find the pointer. I've got it, George, thanks. I'm just going to briefly talk you through a treatment programme of a patient of mine who'd had a gunshot wound to the back of the head, not in the United Kingdom. We have very low gun crime, fortunately. But he was injured in Africa and his family lived in Britain and he was brought back. But because of this gunshot wound, it went in through the occipital lobe, the right occipital lobe, and came out through the left temporal lobe. And it left him with all sorts of problems, as you can imagine. Lots of visual perceptual problems. He'd no depth perception. Word finding problems, object recognition problems, But the thing that bothered him most was he totally lost the ability to read, having been a normal reader before. So that was the goal he most wanted to achieve, was to be able to read again. Now, this is the baseline, and what we did here is we took a baseline on social vocabulary words. So these are things like danger, exit, ladies, gentlemen, words he's going to come across in everyday life. And these are the letters of the alphabet. He's very, very poor. Now, I used an errorless learning approach there, which has been used with children with learning disabilities very successfully. And I was following a paper published with learning disabled kids, teaching them to read these social vocabulary words through errorless learning techniques. I did it as well as I could. A total failure. No difference between that and that. So we gave up for a while. That's what this gap between there is. And then we decided to teach him to read again using the phonetic route. Right? So he was first of all to a, b, k. Then we went through the letters of the alphabet within 3 weeks. And, before we started the second treatment, he had to have another baseline. You always have to go back to baseline first. Then we're teaching him letters of the alphabet, and in 3 weeks, he learned those. Then we test him again on the social vocabulary words that he had not been taught now for several weeks, and the letters of the alphabet. And he's at 100%. So what he's done is we've turned him into a letter-by-letter reader. When he's reading things like danger, exit, ladies, gentlemen, he's having to spell it out letter by letter, but he's a functional reader. And his reading age was above 9 years, just above 9 years then, here. Which is, it's not brilliant, but he can cope with everyday life and cope with very simple newspapers. Now, the reason I'm telling you that is because we go back to that dual model of reading that I talked about just before lunch. We can use this to explain why our treatment was successful. He knew if we were holding up a stimulus, like danger, he could do very limited visual feature analysis. The only thing he could do was to tell you if a letter was upside down or not. Couldn't read the letters, couldn't write the letters, couldn't read numbers. I said to Max Coltart, I have an alexic patient for you. And he said, no such thing. If he's been a normal reader, he will be dyslexic, but he will have some reading ability. Max came to see this man, and then he said to me, well, he is the most alexic patient I've ever seen. He was unable to read anything. He couldn't tell you if they were true nonsense words. He couldn't do any of the reading tasks. But he could tell you if it was upside down or not. Now, we know he couldn't identify the letters. And initially, I'd gone through this route, the whole word route, the social vocabulary words, and totally failed to improve that problem. The second way we tried was this route. Now, in retrospect, what must have been true is that this route was completely wiped out. This route wasn't, and we were able to reteach him through that so he could identify the letters and become a letter-by-letter reader. So that's an example of a model used afterwards to explain what happened. I don't think it would have told us what to do to start with, because we didn't know, till we tried it, which of these two, if any of them, or both, either or both of them, was particularly damaged. Now, I talked about the working memory model earlier, and I said it's been very influential in my work, and I told you about the lady with the visual spatial sketchpad deficit, but I wanted also to just say a brief word about not new now, but relatively new assessment procedure designed by Alan Badley based on some aspects of long-term memory. And it's called the Doors and People test of visual and verbal recall and recognition. And I'm just going to show you visual and verbal recognition tasks. So this is the doors test. And what the person does is they look at 12 doors, one after the other, one at a time, having had a little practice, and they're told, this is a garage door, this is a barn door, this is a front door. They're shown 12 doors, and then they're shown 12 sets of 4, and they have to pick out the one they've already seen. Well, that's probably quite easy for you. It's this one. And even Alzheimer patients are off the floor on that easy version of the doors. So what the test is trying to do is avoid floor and ceiling effects. Now this is also the doors recognition, but this is the harder set, where even young controls are off the ceiling. Now, I'm more a verbal person than a visual person. My left hemisphere is better shaped than my right hemisphere. So when I did this test, I was one of the control subjects in it, where they were doing the validation study. I looked at it and I verbalised it, which is what I instinctively do. So I'm saying in my head, it's a brown door and it's round at the top and it's got a brass handle. And that doesn't really help, because when you come to the recognition phase, they're all brown doors with round bits at the top and brass bits on them. So that's why it isn't a verbal test. It's a visual recognition test. And then in the verbal recognition, you see names of people, one after the other, fairly similar names, and then you're shown sets of 4, and you have to say the one you've seen before. Again, there's an easier version and a harder version. So that's just part of one test derived from a theoretical model of memory. But still sticking with this model, I now wanted to tell you a bit about the central executive, because that's triggered some interesting theoretical work with clinical implications. So this is his concept of the working memory model, central executive, aided by 2 subsidiary or slave systems. And the central executive is our allocator of resources. It's a kind of thing, if you're driving a car with a passenger in your car, and it's a British car with the steering wheel on that side, say, and your passenger's on that side, you can talk to the passenger and drive the car. It's no problem. And your central executive is allocating enough resources to drive the car and enough resources to talk to the passenger. But then suppose a big truck pulls out in front of you. What do? You stop talking to the passenger, because all your resources are needed to focus on the road, and that's what your central executive is doing. And of course, many, many people with traumatic brain injury and other kinds of brain injury have problems with the central executive. Now, I'm going to take you back a bit further in time to Vermont in 1848 in the USA, and an incident occurred which was to change our understanding of the relationship between mind and brain. So how many of you here know about Phineas Gage? Right, most of you. So the Phineas Gage, one of the most important studies in understanding of executive functioning. This is the skull of Phineas Gage, and this is the tamping rod that went through his brain. So he was a 25-year-old railroad foreman and preparing dynamite to drill a hole in the rock when a premature explosion drove the tamping iron, this thing here, 1.1 metres long, 6 millimetres in diameter, and weighing 6 kilograms, through his left cheek and out of the vault of his skull with such force that it threw him on his back, and he fell several metres behind, smeared, the tamping rod fell behind, and it was smeared with brain. He remained conscious. Again, it didn't go into his brainstem. Just like CM on the train this morning, that I told you about on the train, whose the knife went into her parietal cortex, it avoided the brainstem, so they didn't lose consciousness, either of these. So Phineas Gage remained conscious, and a few minutes later, he's sitting in an ox cart writing in his workbook. He recognised and spoke to Dr. Harlow, you see down there, who'd been called to the scene. The wound continued to bleed for 2 days before Gage developed a severe infection, leaving him semi-conscious for a month. He was so ill that a coffin had been prepared for him. But Dr. Harlow continued treatment, and after 5 weeks, Gage regained consciousness. He was blind in the left eye and had left facial weakness, but no focal neurological deficits. He recovered physically, but his behaviour was so changed that his friends said he was a different man. His employers, who regarded him as the most efficient and capable foreman, considered the change so marked they could not give him his place again. So on one level he seems to have no real problems, but his behaviour and his personality are so changed that he can't return to his work. And these are some, an absolutely fantastic book on Phineas Gage by, oh no, that's not the book, that's another book, but the book I know is by Martin MacDonald, an Australian. But these are some scans and, what's the word I'm looking for, but mock-ups of what it would have looked like. So there's the tamping rod going through, blind in the left eye, goes straight through his frontal lobes. Now, here's what we would today say, describe as having a dysexecutive syndrome. Now, Alan Bagley, in 1986, coined the term dysexecutive syndrome to describe the nature of the impairment arising from frontal lobe damage. And Alan and I, in 1988, published a paper based on Rylander, 1932, describing the dysexecutive syndrome. So impairments in attention, they're easily distracted, difficulty grasping the whole of a complicated state of affairs, and these people may be able to work along routine lines, but they have great difficulties in new situations, as we heard Dr. Goldberg talk about yesterday morning. And here is a quote from Nick Goldberg's first book on the executive brain. And I think this captures it well. So he says, the brain's chief executive is the frontal lobes. And a patient with frontal lobe disease will regain the ability to move around, use language, recognise objects, and even memorise information. Yet like a leaderless army, cognition disintegrates and ultimately collapses with the loss of the frontal lobes. Now, the cognitive consequences of these frontal lobe lesions, or the dysexecutive syndrome, cognitively they have planning, organisation and strategy application difficulties. They can't problem solve, they have reasoning difficulties, problems with decision making, problems with sequencing, problems in forming and shifting concepts or mental set, using feedback so they may perseverate, and problems with fluency. Now, let me give you an example of perseveration of one of our patients. She was asked to draw a clock. Now, it's not too bad, a clock. It's not wonderful. Not all the numbers are there, but it's not the kind of clock a neglect patient would draw for you, so it's recognisable. Then she's asked to draw a house. And classic perseveration, we get the clock again. Then she's asked to draw a person, and we get this. Now, most people don't perseverate as much, as severely as that, but this is a genuine patient through our rehab service. Now, the emotional and behavioural consequences, well, emotionally they may be very apathetic, very flat affect, or they may be very labile, and behaviourally, you may have this adynamia, or lack of initiation, or abulia, it's called in some parts of Europe. And then you may have this impulsivity or utilisation behaviour, or the environmental dependency syndrome, as described by Lermite in 1986. Now, utilisation behaviour, or the environmental dependency syndrome, means these people respond to things in the environment inappropriately. So you may have, for example, if I have my comb on the table, the patient might come in, pick up my comb and start combing his hair or her hair. And one patient I knew very well with this syndrome, a number of things happened, but the most distressing thing was he would go into occupational therapy to one of the workshops, and there'd be a little sink in the corner, and he always treated it as if it was a urinal in the gents' toilet. So he always peed in this little bowl. Classic example of the utilisation behaviour. Again, another model of Phineas Gage. But this talks about models and theories and research. So I just wanted to say there are 4 main models that certainly influence our group in Great Britain when we're treating people with the dysexecutive syndrome. Luria's model, Bagley's working memory model, Norman and Challis's model, and John Duncan's model. So I'll tell you briefly about each of those. So this is Luria, who talks about speech not controlling action. So he said in one paper, in these patients, the verbal command remained in their memory, but it no longer controlled the initiated action and lost its regulating influence. So, for example, this guy I was telling you about that peed in the sink thinking it was a urinal, he always went out of a door in occupational therapy that led to another department that he wasn't supposed to go to. And he knew he wasn't supposed to go through this door, but he couldn't stop himself doing it. And in the end, the OTs put up a notice that said, Roger, you have gone too far. And he read it. He could read perfectly well. Roger, I'm not supposed to go through this door. He knew he wasn't supposed to go through it, but the door opens and he goes through. Now, then Challis and Norman's model, or Norman and Challis's model. This is Tim Challis, as some of you will know. And they describe the frontal lobes as acting as a supervisory attentional system. And the supervisory attentional system was described as being required in various situations, but situations that involve planning or decision-making, error correction or troubleshooting, responses that are not well learned or where they contain novel sequences of actions, dangerous or technically difficult situations, and situations that require the overcoming of a strong habitual response or resisting temptation. I go past those little things up there and pick every time, even though I know I don't need any more. But where it happens to me most is my drive from home to Cambridge. I do it over and over again. I know that route so well. And sometimes I don't have to go that way. I have to go another way. And I get to the junction and I find myself on the way to Cambridge because it's such a habitual response. And that means my supervisory attentional system isn't working very well. Then there's John Duncan's model of goal neglect, which I think will be less familiar to some of you here. But John Duncan is a colleague in the same unit as me in Cambridge, the MRC, the Medical Research Council Cognition and Brain Sciences unit. And he says that the real problem with these people with the dysexecutive syndrome is goal neglect. So they know what they're supposed to do, they forget what their main goal is. So disorganisation of behaviour after frontal lobe damage reflects a defect in goal-based search, a failure to constrain the choice of action by its intended results. The patient's able to report what he or she intends to do or has been told to do, and yet this intention does not adequately control subsequent action. So it's very similar to Luria's action not controlling speech. But why this is useful is that Ian Robertson there developed a training called goal management training to try and deal with some of the problems. And that training was directly driven by John Duncan's model of goal neglect. So goal management training, now Ian wrote the first manual, and then Brian Levine, who works in Toronto with Don Stuss, came up with more specific training. So in a paper published in 2000 was a study of the effectiveness of Robertson's goal management training. derived from Duncan's concept of goal neglect as the core executive deficit. And first they did a set of paper and pencil training exercises, and participants were taught to follow a set of 5 stages of goal management. So the first thing, stop. What am I doing? Check the mental blackboard. It's supposed to have a mental blackboard inside their head on what they're going to do. Define the main task. List the steps. Learn the steps. Do it. And then check. Am I doing what I planned? So that's the basic goal management training. And they started off teaching people on these paper and pencil tasks. They had 30 TBI patients, goal management training or motor skills training. They were randomly allocated to one or the other. The goal management training was done in one session, but that lasted 4 to 6 hours. I don't think I'd ever do any training as long as that. And these people improved on the paper and pencil tasks. But then they wanted to see if this would apply to a real-life patient in real-life activities. So they got in touch with us, and Linda Clare and I found a patient for them. And this was a woman, this is Linda Clare. This is a 35-year-old woman who was a university graduate who'd had encephalitis, and I know the Americans say encephalitis, but in Britain it's encephalitis, with all sorts of cognitive dysfunctions. And her main problem that she wanted to deal with was dealing with meals. She couldn't cook meals for her family. And she kept checking things over and over. So we did this goal management training, following that, stop, what am I doing, check the mental blackboard, list the steps. And so she had a checklist of the steps to do and this stop and think rule. And she got better, and that's all published. I mean, she was able to cook the meals for her family. Now, sticking with this problem-solving training, at the Oliver Zangwill Centre, and this was probably going on while you were there, Patapia, we developed attention and problem-solving group intervention. This is John Evans, who was particularly involved in this. This is not the problem-solving group, this is our understanding brain injury group. But it's John Evans who was mostly responsible for this. It was influenced by problem-solving therapy from von Cremon in Germany and goal management training from Ian Robertson. Now, I don't think you'll be able to see this very well, but this is a little template that our patients are given, and they take it away with them when they leave, and they keep it in their pocket. And they follow these, they learn to internalise these steps basically, and they take it away with them when they go, and they apply it to real life problems. So notice the problem, define the main goal, what am I trying to achieve? Is there really only one solution? If it's yes, go there. If it's no, identify the possible solutions and think flexibly and broadly. Decide on your solution, weigh up the pros and cons, plan the steps, carry out the plan, and evaluate, go back. Now, we do this in the problem-solving group as, first of all, with hypothetical problems, and secondly, with real-life problems. So they start off, main goal. Now, a hypothetical problem for our group might be something like this. Your team is playing the next town 20 miles away at football next week. The match has been arranged and you're all going by bus, and the bus company phones up to tell you that they're going on strike next week and there'll be no bus. Right, so that might be the hypothetical problem. Your main goal to get the team to the football match. Is there only one solution? Well, no, there aren't. So the group thinks of various solutions. You could try another bus company, you could go by train, you could get all the people in the team that can drive to bring their cars. There's all sorts of things you might do. Weigh up the pros and cons, make a decision, and then plan what you're going to do. So it might be You know, if you're going by other people's cars, get the car drivers, get the time sorted, get the who's paying for the petrol sorted, etc., etc. And then we move on to real life goals. So we might discuss with the group, and one person might say, well, I've got a driving lesson next week at the same time as I'm supposed to be seeing the psychologist for my individual psychological support group. So they've got this problem. What they're going to do, the driving lesson or the psychologist. And then they go through this template. Now, an interesting development of that has been done with Eliano Mioto, who's in Sao Paulo in Brazil. And this one paper's been published, and there's another one just about to come out in neuropsychological rehabilitation. And they had group 1, group 2, and group 3, baseline period, and then this is the attention and problem-solving group. This is an information and education group, and this is a treatment as usual group. Then they did baseline 2, and then as this group did so much better, the other groups then got attention and problem-solving training. So it has been applied. It's all come from these 2 models in particular, but all been treatments have been derived from that. So the treatment group showed greater improvement on tests, functional multi-element tasks, and the dysexecutive questionnaire. Now, I'll just pause there a minute. I think I'm talking too much. I'm going to maybe miss this bit and go on to a case study. But let's pause there a moment to see if there are any questions about anything I've covered today at all so far. Are any of you working with these patients with these kinds of planning problems and executive deficits? 1 or 2. Do any of you do group treatments for these patients? No. Is that because in Greece people don't like working in groups? Yes? Were you going to say something? Yeah.
No, I think that
oh, you see.
it is possible that we're not as big following group therapy.
All right. You can... Okay. But a lot of this you can do with individuals if you have to. I mean, I'm very much in favour of groups because of learning from their peers, vicarious learning, and all sorts of reasons. But if you have to, you can, most of this stuff you can do individually as well. Yes. Yeah. Well, you have various levels of answer, I think, for that particular question. But my short answer to people is, well, what I'm talking about is problems with planning, organisation, and divided attention. Yeah. Well, I don't think any of them are wrong. I think there are different ways of looking at it. You know, I don't think there's any one theory that explains everything, but that's true of memory, attention, whatever. But they can all give us things that we can help explain. And for that, I mean, I get this question, what is memory? And I use a very simple definition, the ability to take in, store and retrieve information. Dysexecutive syndrome. But then if you're talking to a professional or you're talking to, say, a very educated family that want to read the literature, you give a more detailed and advanced thing. And then if you're trying to use it to help you derive your treatments, you go into it in more detail. But I wouldn't say any of these are wrong or right. I just think they're different ways of looking at a particular problem. Did I see a hand going up over there? No. My peripheral vision's not functioning properly. And, you know, all these models, to me, they're only useful if they're applicable clinically. I come from this MRC, Cognition and Brain Sciences Centre, where everybody's interested in theoretical models, and I'm only interested if I can apply it. And all these models I'm talking about can be applied clinically. So I'm not really going to say too much about emotion, partly because I touched it this morning. George has not done the same talk as this, but he's addressed dealing with the emotional problems and is going to do more tomorrow. But using cognitive behaviour therapy with brain injury, this is one paper, Canborn and Brown, 2003, who talk about how you might have to adapt the typical CBT if you're working with patients with brain injury. So you're probably going to need to use more memory aids, written notes, cue cards, audio tapes. The sessions may have to be shorter. The frequency of sessions may have to be more. You might have to involve family members, using summarising techniques, strategies for keeping on track. You might use some kind of hand signal when people are being too tangential. So again, like many treatments, we often have to modify them if we're going to use them with brain injured people, but at least they're there to be modified. Now, I just wanted to say a word about formulation, because this is a big, big part of our assessment procedure. And I don't know if it's a familiar term to people in Greece. Do you do a formulation when you're doing an assessment of a patient? Some are saying yes. Yes, right. So it's a way of bringing together everybody's different assessment procedures and to have a structure again for start planning your treatment. So let's quickly go through it. You need to look at the pre- and peri-injury factors. So let's take the girl that was stabbed with the knife. Now, pre-injury, she was studying art. She was 19 years of age. She was at college doing a fine art course, a very happy, bubbly girl. This horrible, nasty thing happened to her. We know where the damage occurred. We know she was fully conscious throughout, which made, I think, some of the emotional problems worse. We know about the nature and extent of her losses and impairments. She's got memory problems, visual spatial problems,